Welcome. In this presentation, I'm going to walk you through a modern blueprint for heart failure management. The central idea is that contemporary care is no longer just about giving a few medications and waiting for progression. Instead, we now think in terms of an integrated pathway that combines pharmacology, electrophysiology, autonomic neuromodulation, and mechanical circulatory support. As we move through the talk, notice a progression from early stage disease where risk factor control dominates to symptomatic heart failure, where guideline directed medical therapy becomes central, and finally to advanced disease where device therapy and durable support become essential. The goal is to show that heart failure care is a continuum. At each stage, we can identify the dominant problem, select the right intervention, and keep pushing the patient towards stability, remodeling, and improved survival. Here, the AHA staging framework is illustrated. On the left are stages A and B. These are patients who are at risk for heart failure or who have structural heart disease without symptoms. The focus here is prevention, control blood pressure, diabetes, obesity, ischemic risk, and other drivers of remodeling. In the middle is stage C, where the patients are now symptomatic. This is where the major therapeutic effort shifts towards the four pillars of medical therapy and selected device based strategies. These are typically our NYHA class 1 through 3 patients. On the right is stage D, advanced heart failure. These patients have symptoms at rest or recurrent decompensations despite optimal therapy. At this point, the focus shifts from modulation of disease biology to advanced therapies such as LVAD or transplant. So, this slide frames the rest of the presentation: prevention, optimization, then rescue and replacement. Historically, heart failure treatment was divided rather rigidly by ejection fraction, with 40% cutoff serving as a major therapeutic boundary. That model is still useful, but it is increasingly incomplete. Here we emphasize that left ventricular ejection fraction spectrum is not binary. We have heart failure reduced ejection fraction below 40%, mildly reduced ejection fraction 41 to 49% range, and HFpEF at 50% above. Traditional neurohormonal therapies such as beta blockers, mineralocorticoid receptor antagonists, and ARNI show the strongest signal and reduce ejection fraction and then attenuate as EF rises. SGLT2 inhibitors are different. They have shown benefit across the EF spectrum, which makes them a unifying therapy in modern heart failure care. That is why SGLT2 inhibition has become foundational, not just another adjunct. The four pillars of HFrEF therapy include ARNI, most commonly Entresto, which replaces ACE or ARB, and improves outcomes by combining angiotensin receptor blockade with neprilysin inhibition. Second are the beta blockers, which blunt sympathetic activation and promote reverse remodeling. Third are mineralocorticoid receptor antagonists, which reduce fibrosis and heart failure hospitalization. Fourth are SGLT2 inhibitors, which have broad efficacy regardless of diabetes status. They should be introduced early and move toward target doses as tolerated. When used together, they produce additive benefit. The benefit of SGLT2 inhibitors is not simply glucose lowering. Instead, they appear to trigger cardioprotective cascade that resembles a state of nutrient and oxygen deprivation signaling. SGLT2 inhibition activates low energy sensors such as SIRT1 and AMPK. This leads to enhanced autophagy, which helps clear damaged mitochondria, lowers oxidative stress, and reduces fibrosis. The downstream effect is more favorable remodeling. On a parallel pathway, hypoxia-mimetic signaling increases HIF activity and is associated with erythrocytosis, which may reflect one of the drug's biological signatures. These drugs are not just diuretics, they are disease modifying agents. That helps explain why improved heart failure outcomes across a wide range of patients, including many without diabetes, is noted. Now we come to the biggest real world problems in heart failure management: hemodynamic intolerance. Guideline directed medical therapy clearly reduces mortality, but in practice, many advanced heart failure reduced ejection fraction patients cannot tolerate optimal doses because of hypotension. The issue is that the patient's circulation is too fragile to support the very therapies that would help remodel the ventricle. favorably. This is where strategy has to pivot. If hemodynamics prevent pharmacological optimization, we have to think beyond the medications alone. Electrophysiological and neuromodulatory devices can provide a bridge by improving contractility, synchrony, or autonomic balance. This allows blood pressure and perfusion to stabilize enough for us to reintroduce and uptitrate foundational drug therapy.